you know, I can kind of, a little bit closer even, a little bit closer. Thanks. Not that close. I'm like really picky about where people's, like patients are always sliding up and down. Like, no, a little closer, a little further. Because really I compromise them for the purpose of really making sure I'm in the best position to be able to really assess what's going on. Ooh, so, okay, so she's got some restrictions. Sorry, yeah, when you say ooh, it's not a good thing. The patient's like, what? Okay, so right here she's got some restrictions. So when I feel that and her inability to kind of go down glide in that direction, the next thing I do is I say, okay, there's the restriction. So now I'm going to hold her head. I almost kind of tuck my elbow into my ASIS a little bit. And now all I'm going to do is, excuse me, I'm here, and I'm like underneath, and now I'm gonna kind of like, yeah, next one. And I'm gonna push, take up the slack, and I mobilize in that direction. So I'm mobilizing right there, but see my force direction is to her right. So I'm kind of mobilizing right here, and she should kind of fall a little bit into extension and side bending. Okay, so I'm right there. So you're not lateral, but you're kind of underneath.
Can you show it real quick on the other side?
And then, so we're here like this. Not here, but I'm going to dip underneath. And then I actually position myself. I kind of move because I was assessing here, but now to do the technique, if I find it, I keep my hand right there. I move right into the technique, which is the reason why I'm showing these techniques, because we can kind of translate them pretty easily, so you don't have to learn two sets of things. Instead of being lateral, I'm underneath, and now I kind of move here. I lock my elbow into my ASIS, and now I just kind of get her to relax. I take up the slack. I'm not here doing this, right? I take... Sorry.
We'll edit that out.
I take up the slack. Right, so here's me taking up the slack right there, and that's when I feel the restriction there. And right there is where I start mobilizing. Okay, so I'm not like doing this, but take up the slack. Oh yeah, now it's tight. Now I start pushing. Now this doesn't feel all that great, this particular technique, so this is not used as commonly as I use the upglide one, because it just doesn't, it's not as comfortable for patients a lot of times. But again, if you're looking at needing to restore down glide, that's what we would really be looking at trying to do. If I had a restriction of down gliding on the right, what motions might be limited? Extension, right side bending, or right rotation. So for any of those indications, the patient comes in and they go like this, down glide on the right, or maybe it's an up glide on the left. Right? Either of those we could use. What if down gliding hurts because that's the side that hurts? Well, I might use up glide to restore down glide on the other side. You guys with me? If we think about things only doing this, it makes things a lot easier. You either push this one down or pull this one up. Now ideally, if this is limited coming down, we want to address that particular one. But if that's too painful, we might go to the other side and do up glide, or vice versa. So we can use these techniques to do a lot of things. I mean, these are the mid-cervical techniques that we're going to really focus on, along with the anterior glides that we already did. So I promise to show you guys